Good evening. Thank you everyone for joining us tonight for tonight's annual immunisation update for current and non-current authorised immunisers. So tonight's session is being facilitated by Hunter New England Central Coast PHN and being presented by Hunter New England Local Health District. My name is Charles Broadfoot and I am a Professional Development Officer with the PHN, and I'd firstly like to acknowledge the First Peoples and traditional custodians of the lands in which we're all meeting tonight and pay my respects to elders past, present and emerging. And I'd also like to welcome our Aboriginal friends and colleagues who are joining us online as well. So I just wanted to just promote an event that we're doing tomorrow. So we're holding a mastermind event being run by the PHN at 1 o'clock tomorrow. And this will be on the COVID-19 vaccine rollout and preparedness within your practice. It will be presented by our primary care improvement officers, and also we'll have our COVID leads, Executive Manager John Bailey, and our COVID lead Kim Booth will be available for questions. So if you'd like to register for this event, just head to our website, thephn.com.au, and click on the Education tab. So tonight's session is being recorded, and the recording will become available on our website from tomorrow. So you can access the slides as well as previous recordings by just clicking on the Education tab. So we will be using Slido tonight for your questions and also the evaluation survey at the end. So you can access the evaluation polls and the Q&A tab on the right-hand side of your screen. Alternatively, if you head to slido.com, S-L-I-D-O, and enter the event code IMM. A third option is by scanning the QR code that will pop up on your screen. So please type your questions throughout tonight's session. We have allocated time after the main presentations to go through these with you. We will also have the immunisation team in the background typing answers to your responses. So it's now my pleasure to introduce today's speakers. So firstly, we have Patrick Cashman. Patrick is the immunisation coordinator for the Public Health Unit for Hunter New England Local Health District. And we are also joined by clinical nurse consultants Jodie Stevenson and Sharon Saxby, who are also in the immunisation team at the LHD. In the background, we also have Angela Sherlaw and Rebecca Johnson, who will also be typing responses to your questions. So that's all from me. I'll hand over to you, Patrick.
Thanks, Charles. Terrific. Hello, everyone. How are you doing? Thanks for joining in. So today we try to cover lots of bases. We'll mainly be talking about COVID vaccines because it's going to be rolling out in practices and in the John Hunter Hub shortly. So we'll talk about the different COVID vaccines, where they're going to be used, but we'll also try to package up general information. So for authorised immunisers out there, we used to do face-to-face immunisation updates. This sort of replaces that for Hunter New England nurses, people in our area. So please keep a record that you've attended, and that will suffice for that. But if you're not a nurse, there's a lot in it for you tonight. Jodie's going to be talking about cold chain. Sharon will talk about the school program. I'll talk about COVID vaccines and other vaccines and recent changes to the immunisation schedule. So the world shut down. We don't have any COVID disease in Australia really at the moment. But that's because of lack of travel really and lack of movement. We don't want to live like this all the time. So if we can vaccinate Australia, we've got a little window before the borders open again. This is the right time to be vaccinating people. So this is a huge job. This is a 1 in 100 year pandemic, and you guys are going to solve this problem for Australia and get us back to normal life as much as possible. So it's a huge undertaking. And thank you for joining in, giving up some of your time and starting to understand how we're going to do this. Now, just keep in mind that the COVID vaccine rollout is run by the Commonwealth Government and we work for the state government. So in lots of ways, there's lots of bits of the puzzle that haven't quite fallen into place yet that we're waiting for answers as well. So we don't have all the answers tonight, but we'll see how we go. So Jodie's going to start off, talk about cold chain. Obviously, the vaccines are not going to work unless you keep them properly, and this is much more vital with COVID than even with the other vaccines. Then Sharon's going to talk about the school program, and then I'll finish up. Thanks, Jodie.
Hi, Patrick. Thank you so much. And Sharon and I had a talk at lunch, and we thought next live stream, we're coming in our Jimmy Jams, so we look like you guys. Sharon said no glass of wine, but I can still wear Jimmy Jams and put my feet up. So, As Patrick said, this is massive. This is really big, so take care of yourselves at the moment. Get some good sleep in. So I know we talked about cold chain last year. I just wanted to go through it again because it's super important we get it right. And it's doctors, nurses, receptionists, anyone who's coming into your practice. It's really, cold chain's everyone's responsibility. So as we've stated, cold chain's that important way of transferring vaccines to keep them between 2 to 8 degrees. Our COVID vaccines are super scarce. We've seen that Italy's kept some. So they're super scarce, they're super precious. We really need to take care of them and make sure that our fridges are suitable. With that in mind, influenza vaccine, now's the time to order. You would have all received an email saying, order your influenza vaccine as of Monday, I think it was. When you go on, you'll see your allocation. If you cannot fit those 400 or 500 vaccines in your fridge and you're successful in your COVID EOI, then don't take all 400. Reduce that number of influenza vaccines on the online ordering system. The ministry does want you to have enough for 4 weeks supply, but if you're giving COVID vaccines out as well, you're really going to struggle to fit everything in, and we don't want a cold chain breach and to lose everything. So please check your flu vaccine order and check your fridge and make sure you've got just sufficient room for it all. Okay, so as we've said before, our vaccines are sensitive biological substances that become less effective or even destroyed if they're frozen, exposed to high temperatures, or exposed to light. And the loss of the vaccine effectiveness is cumulative and can't be reversed. Super important with our flu vaccines. Do not take them out of the packaging because you think you can fit a few more in. They need to be protected from light as well. All our vaccines, original packaging. I know I'm going to say that a lot, but every year we get repeated cold chain breaches from vaccines being exposed to light. Okay, so I just want to cover off some AstraZeneca important information. So we've all done our AstraZeneca training. We all feel a little traumatised by it because it was really hard. It was nice reading it and understanding it, and then we had to answer the questions at the end. So I've summarised it for us. So AstraZeneca, same as other vaccines, need to be kept 2 to 8 degrees, and we can keep that for a maximum 6 months or as per the expiry date. Really important, we do not freeze this one. Do not get confused with another vaccine, not to be frozen. Let's keep it in its original packaging because it's light sensitive as well. Once we open the vial, we've got 6 hours at room temperature. Room temperature is said to be 30 degrees. Hopefully your clinics are a bit cooler than that. And then the total time, including your 6 hours sitting on your desk, or less than 6 hours, is 48 hours we can store that vial once it's been opened. So it's really important in your, is it onboarding kits that you're getting? It's got little labels you can use, so it's really important we time that really well and clearly so we can clearly see the 6 hour mark and the 48 hour mark. So you've kept your vaccine on your desk waiting for people to arrive. It's 5 hours and 50 minutes gone. Pop it back in your fridge so you get some more time with it. This is a really important number that you need to have recorded. Your Vaccine Operations Centre and your SHIOC. So as Patrick said, this vaccine's different in that it's all coming from the Commonwealth. We're not getting information the same time as you and GP land are. We're getting it about the same time as the hospitals are getting it, maybe a day later. So it's really important you have these numbers handy. Vaccine Operations Centre, the 1800 318 208, and the SHIOC on 9859 5690. So AstraZeneca contains no preservatives. So that's what's impacting our timeframes. If either limit is reached, then that vial needs to be discarded into your clinical waste, so into your sharps bin. There's no thermostability data available for excursions outside of 2 to 8. So at the moment you report cold chain breaches and we have thermostability data on all the other vaccines in your fridge, And we can let you know, there's been a few hours at this, it's okay. We have none of that for AstraZeneca. So it's really important that you adhere to the 2 to 8 and the 6 hour and the 48 hour mark. According to the training package, it says that if 5 or more vials need to be discarded at a time, which I'm not really sure what a time is, then you have to call the Vaccine Operations Centre and the SHIOC. Normally you'd call us, but vaccine discarding, the VOC and the SHIOC. And there's another bit in the training module that talks about the stability of the vaccine after being drawn up into a syringe has not been studied, therefore it should be used immediately. And I know lots of you are asking us questions, what does immediately mean? And that's a really cool question. And we were talking about it too. In the latest information that came out from New South Wales Health yesterday evening, it talks about, sorry, I meant to highlight the bit. It talks about using it within the time frame. And I'm taking the time frame to be that 6 hours, but I need to double check. So when you see the information from New South Wales Health, it's a little bit different to the training module. But we will clarify and make sure that that's put into the toolkit that the Primary Health Network is putting together for you. And one of the other questions, so you'll see for those of you that have been looking at the information, there is conflicting information between ATAGI, between ASCIA, and we'll try and answer those questions tonight. And if we can't, we'll certainly get back to you with the best answers that we know. So that's all I can tell you about your AstraZeneca vaccine at the moment. Keep those timeframes in mind, get your labels ready, get your phone numbers down for SHIOC and the VOC. Now let's talk about all your other vaccines, including your flu vaccines. They need to be stored in purpose-built vaccine fridges. Remember, domestic fridges are right out and bar fridges were never really in, but they're definitely right out. This fridge needs to be serviced every 12 months. If you haven't done it in 2020, now's the time, perfect time. All vaccines, like we were saying, need to be stored in their original packaging. No vaccines should be stored on the bottom shelf. And we know that you are because we are doing cold chain audits and we see the photos of your fridges and we see the vaccines on the bottom shelf, and then we get back to you and say, don't do it. So please, if you've done it now, go get your baking trays tomorrow, your wire ones so air can circulate around them, and take all the vaccines off your bottom shelf. Strive for 5 clearly says not to be put there. Not to be touching the sides, they can get too cold, don't overcrowd your fridge. And the recommendation is to use open weave baskets. They can have solid bottoms, but open weaves on the side. Okay, data loggers. 5 minutes, just 5 minutes. Some of you have online cloud-based monitoring, and that you can set that for 3 minutes, you can set that for whatever, but when you send the report to us, we need it in 5-minute intervals. Same with your tiny tag and your other one, log tag, thank you, 5 minutes. Now's the time to change the batteries on your data loggers for those that can be changed. So log tag, I think you can get those batteries from Hastings, wherever you ordered your log tag. It's your tiny tag. Tiny tag, you can change the batteries. Your log tags, only some of them you can change the batteries. The other ones only have a life of up to 18 months. Batteries changed as per the manufacturer discussions or recommendations or every 12 months. And this is how you check your batteries. And these slides will all be available, and please just call us. So you can see the log tag on the left, it says okay, battery status okay, anything other than okay, you need to order your new log tag straight away. Your tiny tag, it says good. Anything other than good, you need to change the battery or every 12 months. So with your tiny tag, when you're doing your calibration, you can do that in your clinic. So you can see I've highlighted the little clock. So that's telling you what temperature your data logger is when it's plugged into your computer. So you can see at this point, our room temperature was 22 degrees. So you need to get a plastic bag, pop your log tag in it, get lots of ice, some water, pop your log tag, tiny tag, in its bag, in the ice, and you'll be able to measure when it gets down to 0. And you've done your calibration. Write that on your tiny tag and write it on your annual self-audit that you're all doing now. Thank you, I'm very proud of that. Your min-max thermometer. So I know your fridges all have built-in min-max thermometers, and that's super cool, and they're all up really high that none of us can reach. You also need, as per STRIFA 5 and New South Wales Health, a battery-operated min-max thermometer. This is GPs, this is hospitals, this is anyone that's storing vaccines. So it's the two things, purpose-built fridge and the battery-operated min-max thermometer. Two reasons. One, when the power goes out, you still know what your vaccines are up to, and you can move that probe all around your fridge so you know your hot spots and your cold spots, because you might find that you can't store vaccines right outside on the top of the fridge where the fan is. It might get too cold. So that battery needs to be changed every 6 to 12 months and accuracy checked every 12 months. Those batteries are just available from your local chemist. You can order those min-max thermometers through your supplier. This is how to check your accuracy. I think most of us are doing it. For those that aren't sure, it's in STRIFA 5, cup, water, ice, probe in, check the temperature after 2 degrees, make sure it gets to 0. These are the stickers that we need you to have. So these stickers do not turn off power. So that goes out on your power box outside, and we had a cold chain breach only yesterday where an electrician had come along and turned the power off without letting people know. So those vaccines had a cold chain breach. Do not turn off before consulting the person responsible for the vaccine management, and stop, do not open the door till you know what you need. They're really cool. They need to be on Pepsi fridges as well. And you need to have vaccine management policies that are reviewed every 12 months. We can send you some, or they're in STRIFA 5. STRIFA 5 Appendix 8 and 9, super handy. Daily temperature graphs. That's every day your surgery is open. You need to be recording the temperature morning and night, and you need to be doing it like you would a blood pressure. So these are the GP requirements. They want you to use this form, this min-max form. The back of that form is for your information. So every time you put vaccines in your fridge and your temperature goes up, write it on the back of your temperature graph, because next week when you download your logger, you're going to forget why your fridge went up to 12 degrees. So it's really important that everything's recorded on the back of your temperature graph. And I've just done an example of how to record your min-max. So we put the highest, we put the lowest, then we put the current, and then we reset our thermometer. Don't reset your thermometer first, record the temperatures, then reset it. If in doubt, give us a call. We're all over cold chain now. So these are the protocols that are required. So for your hospitals, your private hospitals storing fridge, you've got QARs that you need to do annually. And this is the vaccine fridge protocol. They're all available on the New South Wales Health website. STRIFA 5 is your best friend. So you've got really two resources available to manage your fridge. STRIFA 5 is the national resource. It's really good. New South Wales Health has then broken it down to the New South Wales Cold Chain Management Toolkit. And it's available on the New South Wales Health site. You can get the link from our website. So these are two really important resources that you need to be across. Here's your poster for managing a cold chain breach. Really important. When you ring us, not for your AstraZeneca, when you ring us for your other vaccines that have gone out of range, the first thing we're going to say is do not discard anything and put a sign on your fridge saying do not use, cold chain breach has occurred. And then we're going to send you a cold chain wastage report form, and you're going to send that back with your data logger. When you send back your data logger, don't send us a PDF or a picture of your graph. We need the file from your data logger, the same thing you look at, so you can make the graph bigger or smaller and see the exact numbers so we can work out the exact time frame that it's been out of range. So it's really important. Cold chain breach, non-AstraZeneca, still call us. Label your fridge, do not use. Download your data logger and get ready to send it through to us. We're still working on our cold chain audits, and I can't thank our PHN friends enough who have contacted most of you and asked you to do your random New South Wales cold chain audit. It's just taking longer than I anticipated because I thought we'd all get 100% and it would be super easy. But everyone that we've done so far, bar 1 or 2, has required lots of corrective action, and that's why they're taking so long. So if you've sent us your cold chain audit and you realise that it's not correct, that your photos were showing vaccines in your fridge or open boxes, or you haven't sent through the right data logger, please take some time and resend it. Otherwise, we're just going to contact you and make you send it, or ask you to send it again. So thank you to everyone that has done your random cold chain audit. We've done heaps, but we haven't done them all. We're still working on them. We're going to try and prioritise all the GPs that were successful in your EOIs for COVID vaccines. So I think Patrick's going to ask who you are, so you can tell us. There's your toolkit. And here's the take-home list that we've discussed before. Rotate your stock. Ensure you've got your battery-operated min-max thermometer. Ensure the battery's changed every 6 to 12 months. Ensure your fridge is serviced every 12 months. Now's the perfect time. Ensure your data log is set for 5 minutes. Ensure no vaccines on the floor of your fridge, that they're all in their original packaging. Ensure other staff, not just you, know how to download your logger and how to attach it to an email. Complete your annual Strive for 5 audit, and again, consider purchasing an extra purpose-built vaccine fridge, especially if you're going to have COVID vaccine as well. I know Patrick's just bought one, and there's not that many left in Australia at the moment, so now's the time. The other thing, this is additional resources, again we'll send you these slides. The other thing I just wanted to quickly mention is childhood immunisation rates. It is essential that we keep our immunisation rates high. It is essential that we don't have a measles outbreak once our borders open and we start getting visitors from overseas that haven't been able to maintain their health services. So please check the kiddies coming into your surgery, make sure that they're up to date with all their vaccines. No kiddie should be left unprotected or vulnerable to vaccine-preventable diseases. Paula and Natalie, who work with Hunter New England, amazing Aboriginal health workers, are calling every mum of an Aboriginal barb that hasn't got Bexzero showing on air to find out what happened. Were you aware you were meant to have Bexzero? And most of the mums were saying, no one told us. So these are Aboriginal mums bringing their bubs to your service, or mums bringing their Aboriginal bubs to your service, not being told that Bexzero is recommended and funded for their babies. So just a reminder, Bexzero is funded up to 2-year-olds. Aboriginal bubbies have 4 times the rate of meningococcal B. So it's really essential that we protect all our families from Bexzero, from meningococcal B. So that means if we start under 12 months, they get 2 doses plus a booster dose. If they start over 12 months, they get 2 doses 2 months apart. If they start under 2 years of age, we finish the course. Over 2, it's no longer funded. If in doubt, give us a call. I think that's all I want to talk to you about for now. I'll hand over to Sharon, who's going to talk about the exciting world of the school program.
Thanks, Jodie. Hi, everyone. And we all thought that last year was a bit of a hectic year. I don't think we have any idea what this year's going to be like. But busy, busy, busy. And I have to say, I never thought I'd say that the school program was an easy project. But having been involved in COVID vaccine rollout, I understand that it is a fairly straightforward project, but it's a really important program. And I'd just like to remind everybody what's involved in the school program. So as you can see, the school program is a program that's run between, or it's a union between Education Department and Health. And we go around all of the high schools we go all around the high schools in Hunter, New England, offering vaccines that are recommended for our adolescents. So this involves, go figure, it involves giving a consent form to a student to take home for their parents to read, to sign and bring back to school. So there's nothing that could ever go wrong in that project. So this is what the students take home in Year 7. They take home an envelope like this. I thought I'd just show you guys because you will get parents asking you about the school program and asking you what to do with these things. So this is the envelope that goes home. Inside these envelopes is a whole swathe of information. So there's a consent form that we'll have a look at in a minute, but there's frequently asked questions, there's information about each of these vaccines. Probably the most common questions we get with Year 7 is, number one, what are the ingredients in the vaccines? And that is included in the information in the consent package, but also why is my son getting a HPV vaccine? I get quite a lot of calls about that. So it's really worth having conversations with your Year 7 parents about why we're vaccinating our sons for HPV and all the different cancers that are caused by HPV in males. This is what our consent form looks like. Every now and then we get consent forms that have obviously been taken to you guys and the GPs have signed them as giving vaccines. These consent forms are only for within the school program. So to avoid confusion, if the parents present with these forms, please vaccinate the child, but don't sign these consent forms. And this is the Year 10 vaccination program consent form. This goes out to our Year 10 students for meningococcal. And once again, inside there's a parent information pack with loads of information that is similar to the one in the Year 7. And this is the Year 10 consent form. Same thing, if they present to your surgery with this form, please vaccinate them, but don't sign these consent forms. They're for school program use only. So what is the schedule? It's remained unchanged for the last couple of years. So in Year 7, we offer 2 doses of HPV vaccine, Gardasil 9. They have to be 6 calendar months apart. So not just 6 sort of months apart, but 6 calendar months. So same date, but 6 months apart. So it's really important if these students come to you because they've missed their first dose of vaccines in the school program, that those doses that you give go on to the AIR, because we will endeavour to catch them back in the school program for their second dose. We also give them a Boostrix. This is their first adult booster of DTPA. And in Year 10, we give them the meningococcal ACWY, their Nimenrix vaccine. We have expanded our catch-up program this year at school, just so you can let parents know. If the students miss their vaccines at school and come and ask you, we of course would prefer that they stay in the school program because that helps us with continuity of data. But if they insist being done with you, that's fine. But just let them know that they can come back to the school program. And if they've returned their consent forms while in Year 7 or in Year 10, we've got the whole next year to catch them up as well in the school program. So all of Year 8 and all of Year 11. So they've in fact, they've got 2 years to get their school vaccinations. We send each child home, each Year 7 child home with a record of vaccination card. So if they can't produce one of those, there's a good chance they haven't been vaccinated, despite what they tell their parents. And so that's a really important one. The Year 10 students, actually, their consent form gets ripped in half, and one half is their record of vaccination card. So just to let you know how big our program is in Hunter, New England, I thought I'd share with you that overall we have 145 schools. So this gives you a bit of perspective as why I think this is an easy program now after being involved in COVID. So we do 150 schools. We see 12,000 Year 7 students and about 11,000 Year 10 students each year for vaccination. We have 25 teams and we employ about 196 nurses. So it's a really big program, but it's a really worthwhile program, and we really appreciate the way that you guys support us in that program. And please don't hesitate to call with any questions. So that's about all with the school program, but let's follow on from that. And this is why I can tell you why the school program is an easy project. As you have heard, the John Hunter is running out their vaccination hub as of next Monday. So the Commonwealth have finally decided that there are people that live outside of Sydney. So we're being benefited with some vaccines. Now, just a reminder that the vaccination hub at John Hunter is not for everyone. It's for very specific people who have been identified as 1A category people. These people include ambulance and patient transport staff, emergency department staff, critical care ward staff, A&Es, COVID clinic staff, the people who are testing, COVID ward staff, immunisation clinic staff, lab staff, and as such. So those people will all be targeted and communicated with about arranging an appointment at John Hunter. But as we know, vaccine is rolling out through you guys, and that is a really important aspect for the whole community, because there's a lot of concern out there and a lot of people desperate for their vaccine. And actually on my way in tonight, to do this presentation, a guy pulled me up at the front door and said, "Can I get my vaccine inside?" And I said, "Oh, nope, not today." And he said, "Well, what's this immunisation bit?" I had my name tag on, for crying out loud. And I told him he had to go to his GP. He was quite happy with that. So just in case you hear about John Hunter Clinic, that is for specific people. And that's me done. Thank you very much.
Thanks, Sharon. John Hunter Clinic starts on the 15th of March. And for those that know your classics, you know that Shakespeare's Julius Caesar, the soothsayer, warned Caesar not to go to the forum on the Ides of March. But John Hunter wisely decided to kick off their Pfizer hub on the Ides of March. So let's hope we have better luck than poor old Julius. And we save lives rather than bump into Brutus. So we'll talk about various things, thanks to Jodie and Sharon. And Sharon's got a huge role in the John Hunter Hub, and so does a lot of other people. It's a huge undertaking to get that going, and thanks to Sharon. Running the school program is really good training for doing that. And there I have a blank slide for you. The authority for nurses to give vaccines has been altered, so if you do a little bit of extra training, if you're already an authorised immuniser, do a bit of extra training, you can now give the COVID vaccines, and that extra training is, of course, the training that's online on the Commonwealth website. But I'll really throw a spanner in the works. I'll talk about quickly 2021 influenza vaccine. Now, there's no one out there watching this that's thinking about influenza vaccine, but it's going to happen, and it's going to come to your practice soon. So the vaccines this year, there's 2 vaccines available for children, 6 months to less than 5 years, and that's 2 doses if it's the first year they've had that vaccine, and those 2 brands are Vaxigrip Tetra and Fluarix Tetra. So they're the 2 that are on the NIP. They're free, and we know that all children in New South Wales are funded for influenza vaccine. Now, between 5 years and 64 years, there's 3 brands on the NIP. The 2 we just looked at, Vaxigrip Tetra and Fluarix Tetra, plus Alfuria Quad. So Alfuria Quad, you can only give to people over 5. And you remember in 2010, the CSL Fluvax vaccine, there were lots of kids that had febrile convulsions. That was the CSL vaccine. Well, Alfuria Quad is the Seqirus vaccine, which is the same company. So the TGA still don't want them to be giving their vaccine to people under 5. So please don't do that in your clinic. And children under 9, if it's the first year they've received the vaccine, get 2 doses. And then 65 years and over, the Flu-Ad Quad is got the extra adjuvant in it. So it's a stronger vaccine, if you like, for older people whose immune systems might not work quite as well. So Flu-Ad, it's got that adjuvant, it's got an additive, so we only use it for 65 years and over. So again, it's really easy to make errors with vaccines. So it's really important that you know your vaccines, you know what's in the fridge, and that you're giving the right vaccine to the right person. This is the same set of information from ATAGI in a table, but this includes the vaccines that are also not on the NIP. So vaccines that you might be writing a script for, giving it to, I was going to say travellers, but that's not going to happen in the next few months, but hopefully after that. So the ATAGI information is really, really useful, but those previous graphics come from the New South Wales one-pager that you can put up on your clinic, and just check you're giving the right influenza vaccine to the right person. And Jodie told you about ordering influenza vaccines earlier in the session. So co-administration of any vaccine and COVID vaccine, essentially no. COVID vaccines are too new, we're not going to give them with anything else. So always give COVID vaccine by itself. And the ATAGI advice is to separate an influenza vaccine from a COVID vaccine. So if you're a doctor or nurse working at John Hunter and you're going to get Pfizer vaccine at the John Hunter Hub, then you'll be getting, you can think about it as 1-2 flu. So you get your first 2 Pfizer vaccines, and then afterwards follow with the flu vaccine. A lot of people will be getting the AstraZeneca vaccine. And for people in phase 1A, the COVID vaccination should be received as soon as possible and then receive the influenza vaccine. People in later phases should receive the influenza vaccine as soon as it's available, and then the COVID vaccine when it becomes available. So there's no sense of delaying the influenza vaccine in this case, but we're not giving them 2 together. Now, if you happen to, if people happen to get the COVID vaccine and the influenza vaccine in close proximity, that's okay. You don't have to repeat the dose or change anything. Just a reminder that Aboriginal immunisation is really, really important, and everywhere we meet in this country is Aboriginal land. And if you've got Aboriginal patients, it's really important you check the schedule and give the right vaccines, and we'll be talking about that shortly. So there were some changes to the schedule halfway through last year. Some of you, most of you will be across that really well, but we'll just remind you. And the first ones are pneumococcal vaccinations. Pneumococcal vaccinations. So these changed at the beginning of this financial year, on the 1st of July. If you look at the solid bars there, they're Aboriginal people of various age groups with invasive pneumococcal disease. So invasive pneumococcal disease is septicemia, pneumonia, invasive disease. We also know that pneumococcus affects ears and external, but this is invasive pneumococcal disease. And the rates are much, much higher in Aboriginal people, so the schedule's slightly different for Aboriginal people. So this is the new schedule. So we've had lots of different pneumococcal schedules over the years. It's difficult to keep up, but this new schedule's quite nice to follow. So all children on the far left-hand side there, all children, and including Aboriginal children in New South Wales, receive 3 doses of the 13-valent conjugate vaccine at 2 months, 4 months and 12 months of age. So the conjugate vaccine, it has 13 different serotypes of pneumococcus, but the conjugate vaccine works really well. So even though it's less serotypes, it's 13 rather than 23 in the other vaccine, in the polysaccharide vaccine, it works really, really well. So it has a much better immune response because it's a conjugate vaccine. So that's why we give it to children. So before we had the conjugate vaccine, the polysaccharide vaccine didn't work in children under 2 at all because small children didn't recognise the sugar coat on the polysaccharide vaccine. But the conjugate vaccine is attached to a carrier and that the child's immune system recognises that really well and builds up really good immunity. And if you talk to GPs in New South Wales that were working in Aboriginal health in the early 2000s, they report a huge improvement in Aboriginal kids' health after this vaccine was available in New South Wales. Now, if you're working with at-risk children under 12 months, then they receive extra doses. So they receive the same dose at 2 months and 4 months, then an extra dose of the conjugate vaccine, Prevnar 13 at 6 months, and then the same 12-month dose, and then followed up with 2 of the polysaccharide 23-valent vaccines at 4 years and 1 5 years later. Now, for all people over 12 months, that includes adults, all people over 12 months, with any type of diagnosed risk condition, this is the schedule you follow. So this is the one in the middle. So this is for all people, Aboriginal people and non-Aboriginal people with diabetes or any risk condition for pneumococcus. So that's 1 13-valent vaccine conjugate vaccine, Prevnar 13 at diagnosis. Then 2 to 12 months later, usually 12 months is best, the 23-valent Pneumovax 23, and then another one 5 years later. And what this schedule has is that after you've had 2 doses of the 23-valent Pneumovax 23, you don't have any more of that vaccine in your life. So just 2 in a lifetime now, usually 5 years apart. Then the 4th column there, the second last one from the right-hand side, is for Aboriginal people at 50 years. So at 50 years, receive a Prevnar, then a Pneumovax 23, 2 to 12 months later, usually 12 months, then 1 5 years later, then stop. And then this is a big change at 70. So we were giving all adults a Pneumovax 23 at 65. This has now changed to 1 Prevnar at 70 because the vaccine works much better immune response for older immune systems. Now, if you've got someone who's between 65 and 70, they did get a Pneumovax 23 at 65, we still give them the Prevnar 13 at 70. So still give them that vaccine. So if you've got 70-year-olds that haven't had the Prevnar, then you can give them that Prevnar. So that's the schedule. This is a really nice thing to have up on your fridge. That's the schedule for pneumococcal, and that's represented on the usual schedule that we had up before. So what are the risk conditions we're talking about? Well, some of them only have small groups of people, so CSF leak, but a lot of them are very common. So chronic respiratory disease, chronic kidney disease, cardiac disease, diabetes, smoking and harmful use of alcohol. So not all of these groups are funded, but it's really, we want you to be permissive with the vaccines and give them to people who need them. Now, so that's pneumococcus. So there was also a change last year for meningococcal B for Aboriginal children. So this is the Bexsero vaccine. So the Bexsero vaccine is the reverse engineered vaccine for meningococcus B. So meningococcus B is really technically difficult to build a vaccine for. So this is used reverse vaccinology, where they started with the genome and worked backwards to build the vaccine. So this vaccine is available on script for children. A lot of you would have written scripts for children whose parents want to protect them from meningococcus B. So nearly all the invasive meningococcal disease we see in children under 12 months is B. So this is the best vaccine for them. And then again, we see a spike in older teenagers. So if you're writing scripts for people who are purchasing Bexsero, they're good age groups to concentrate on. But for Aboriginal children in New South Wales, it's on the schedule at 6 weeks, 4 months and 12 months. So if the child misses those age groups, there's catch-up up to 2 years of age. So if you've got a child who's more than 12 months and under 2, an Aboriginal patient, you can give them free Bexsero 2 doses. Now, if they're late with their first dose, so they might have their first dose at 6 months, and then they come back at 12 months, they've only had the 1 dose, so we give them 2 more. So they still need their under 12 dose, second one, and then 1 after 12 months. So that would be 3 doses. If they commence under 12 months, they need 3 doses. If they're commencing between 12 months and 2 years, they need 2 doses. The free catch-up finishes at 2 years of age. So that's really important. So why are we doing that? So this is invasive meningococcal B disease in Australia. The blue bars are Aboriginal and Torres Strait Islander people, and the red bars are non-Indigenous people. And you can see there on the left-hand side, children under 12 months of age, Aboriginal children terribly overrepresented, risk ratio of 6.1. So that's why that vaccine's funded in that age group, because it's absolutely life-saving. So if you've got Aboriginal patients under 2 years of age, really mention it to the parents. And this again is all age groups. So you can see there the solid blue line is Aboriginal children. No, that's just all Aboriginal people. This is the different serotypes, apologies. So the blue line there is serotype B. The red line there is serogroup C, and you know we've been giving that vaccine for nearly 20 years. And the green line are other serotypes. So you can see there that the dark blue line, this is data over 10 years, 2006 to 2015. The dark solid blue line, that for Aboriginal people, the B is very predominant. That's why we give that vaccine at that age group. And again, if we can protect children, we stop carriage throughout the community. There are other risk conditions where people need additional doses, and that is complement deficiency, treatment with eculizumab, or people without a spleen. So you'll look after lots of people without a spleen. So for small children, they get an extra dose at 6 months of age. So that would be 2 months, 4 months, 6 months and 12 months of age. So there's a study from the United Kingdom. So in the UK, they've been giving Bexsero to all children, not just small groups, but all children in the UK for 5 years. The UK schedule is really interesting. They've not long introduced hepatitis B for children, which we've been doing that for over 20 years. But they've been giving Bexsero to all children in the UK because they had higher rates of meningococcal disease than we have in Australia. And they found that by giving the prophylactic paracetamol, it really decreased children getting fever, bouncing into ED and getting unnecessary antibiotic treatment. And that's what the conclusion of this paper was, that it's really worthwhile giving the paracetamol at the same time or before you give the Bexsero, and make sure that parents have got paracetamol at home. Now, if the child comes in, especially an Aboriginal child where it's on the NIP for them, it's really important that you vaccinate the child. Don't send the parents away because they haven't given them paracetamol before. You don't want to miss that opportunity to have that vaccine. Now the handbook, I'm sure there's a nice, youthful, young, talented audience out there who can get around the electronic handbook very well. I find it still a bit tricky. But one really good part of the handbook is they've got some great infographics, really worth having a look at. Find something of interest and put it up in your clinic room so people can see it. But it is worthwhile looking around the handbook. Vaccination for travel. So this is a well-known thing to everybody out there. This is the International Certificate for Yellow Fever. This changed recently. You only need one dose in a lifetime now. It used to be every 10 years. Now it's only one dose in a lifetime. And of course, Alan Joyce and his friends are looking at COVID vaccines and international travel and maybe an international passport. So this is going to be, COVID vaccines may become a travel vaccine. You may have patients that are reluctant to get one of the COVID vaccines that'll be in your fridge soon, but they may come back to you when they're planning travel next year. And the tricky thing with the COVID vaccines, I'm going to talk about COVID vaccines for the rest of the time. The tricky thing about COVID vaccines is we don't have any disease in Australia at the moment, but that's because of social distancing, closing the borders, quarantine, all those factors. Now, when we start to give vaccine, the borders will start to open and COVID will come into the community. There's no COVID in the community at the moment, but COVID's going to come in. So we're actually going to have more COVID disease. You'll be seeing and diagnosing more COVID patients at the end of this year than you will at the beginning of the year, because things will open up. So this window of vaccinating people for COVID when there's no disease is a really precious time. So we really want to make sure we give as many people that COVID vaccine, and all your skills of talking to people, because about 30% of people are reluctant to have the vaccine. So that doesn't mean you cajole them into it and bully them into it, but it means that you give them good clinical information and let them make up their minds, and hopefully they'll have the vaccine. But you may see some latecomers come to you when they go buy a ticket, and Alan Joyce won't let them travel unless they have the vaccine or something like that. So there'll be lots of things changing. Now, does the vaccine work? Well, there's starting to be a trickle of information. They've been giving the vaccine since early December in the UK. This is from Public Health England. This is the blue line there, hospitalisations of people over 75. You can see there that at the end of the last year, there was a big spike, and then London closed down, England closed down, much more draconian closed downs than we've ever had here in Australia, even in Victoria. And I have to slip in a mention of Dan Andrews for Todd's benefit. So he hasn't got COVID, but he's had a fall, the poor bugger. So there's lots of dangers apart from COVID. So this is people over 75, and you can see there on the right-hand side, the numbers have really, really decreased. So in England, huge big spike, now the numbers are decreasing. Now, so are the numbers decreasing because of the lockdown? Yes, absolutely. Less disease transmission, less people going to hospital. But the people in Public Health England think that that decrease we see on the right-hand side of that blue line is much sharper than they've seen before, and they think that's a vaccine effect. So they think the vaccine's having a huge impact. So I think they've given over 15 million doses there in the UK, and they're already starting to see the benefit. And they started with, like a lot of vaccine programs, like we've just been talking about with Aboriginal kids, started with the people most at risk. So they started with older people in the UK. So it looks like in the real world, the vaccines are really good at stopping disease and stopping hospitalisation. So in Australia, we've been very lucky. We haven't had big burdens in ICU. We haven't had big burdens in general practice of people crook with COVID disease. We're probably not that good at diagnosing it yet. But in England, it's a very different picture. In Europe, and in the United States, and of course closer to home in India and Indonesia. And there's other countries that have done really well, quite famously Taiwan. So it looks like in the real world the vaccine has a real role in stopping disease transmission. So we really want to vaccinate. Now, there's lots of people who are really nervous about having the vaccine. You'll have lots of patients who'll be nervous about having the vaccine. A lot of Aboriginal people are nervous about having the vaccine. This is some information from, this is a news article from Darwin, and RTB was happy to have the vaccine, but she said a lot of people Aboriginal people have been forced to have things in the past and quite nervous about the recommendation to have the vaccine. So NACCHO, the National Aboriginal Community Group organisation, have a really good website with some really good information. So if you're looking after Aboriginal patients, you really want to use this. So there's some great clips there of some young Aboriginal doctors talking to community. Now, communication, it's one thing for the scientists to make the vaccines, and that's what we're going to talk about shortly, but your role is really in the communication with people and giving them the confidence to have the vaccine. So this is a really useful communication handbook. It's an international one written by and for an international audience. But one of the main authors is Professor Julie Leask from Sydney University, and she's one of Australia's experts on communication, the social science of vaccines, and she heads up a group called COSI, which is a social science on immunisation group. Professor Margie Duncan from Victoria, who you may have seen at our conference 2 years ago, is one of the leads there as well. So this book is really good, and it's actually got some scripts in it. So if you want to know how to talk to people about COVID vaccine, you may find this really useful, and it's just available free on the internet, and thoroughly recommend it if you're wondering how to talk with people about COVID vaccines. There's lots of different aspects of COVID vaccines, but communication is a really, really important aspect. And if you're confident in what you're doing, people will follow your lead and happily have the vaccine. And the other thing is, people are really worried about medical errors. So it's really important that you get it right, that you're giving the right dose in the right place to the right person at the right time. So we see there's a condition called SIRVA, which is shoulder injury related to vaccine administration, where the vaccine isn't given properly. So make sure you give the vaccine in the deltoid muscle. So make sure you get your anatomy right. If someone's wearing restrictive clothing, make sure you view the site properly and give the vaccine. It's a fairly simple medical procedure, but it doesn't mean that you're careless. You might be doing dozens and dozens a day. It doesn't mean that you're careless. So getting the right dose. We saw one doctor in Queensland give several doses to someone in a nursing home, and that caused a lot of consternation in the community. And if you make mistakes, it'll really worry people. So getting things right is really important. As far as medical procedures go, vaccines fairly straightforward, but it's still possible to make mistakes. Make sure that's not happening in your practice. So COVID, we just saw on the UK data there that it's really people over 75 who end up in hospital more than other groups. But there are conditions that will affect younger people. So this is not a trivial illness. We know about 10% of people in North America, in the UK, get what's called long COVID, which is a whole constellation of various symptoms that knock people off their feet for quite a few months. So this is not what we want for our community. So we really want to bump up those vaccinations so that people are covered when the virus comes. Because the virus is coming. The question is, how many people can we get vaccinated before the virus comes? The virus is coming. So just remember that the coronavirus is really, really common. There's hundreds of different coronaviruses in animals. Famously, it jumps over to humans, like we think happened in wet markets about a bit over 12 months ago. There's 7 known coronaviruses that cause disease in humans. 4 of them are really common. 4 of them cause the common cold. 4 of them you would have had, and you would have written 6 certificates for patients that have had those 4, but we don't test for them. We don't recognise them. But SARS in 2003, about 800 people around the world died of SARS. So SARS is a coronavirus as well, jumped from animals to humans. But happily with SARS, you could only transmit it when you had symptoms. So it was possible to identify someone with symptoms, wear PPE and protect yourselves. Now, a lot of those 800 people who died were doctors and nurses who were treating people in ICUs and in A&Es and got infected and died of SARS. So coronaviruses are very, very tricky, but happily SARS was able to be stopped before there was a vaccine developed, because with infection control you could tell who was sick and protect yourself as a healthcare worker. That does not the same with the SARS-CoV-2 that we're dealing with at the moment, where asymptomatic transmission can occur. Then MERS, of course, in the Middle East, and that's still there, but because it's transmitted through camels, it's not very common. And then SARS-CoV-2 that we know all about it and causes the disease COVID-19. So they're the 7 coronaviruses that affect people. Now, the Australian government have purchased lots of vaccines and have a plan for vaccinating people and for quarantine workers and border workers. And in Victoria, I think they're doing their families as well. They're the front line. That's where, all the outbreaks that we've seen really in the last 12 months in Australia have come through quarantine hotels. They're the front line, and frontline healthcare workers are 1A as well. And the Pfizer hub at John Hunter, starting on the 15th of March, will be the Pfizer vaccine. So that's the vaccine that's transported at -70, and that'll be available to frontline workers, but also in Newcastle to ambulance officers, port workers, people dealing with people on the ships, people from Lake Macquarie Private ED, so they're frontline workers. Sharon, remind me, where else are we giving the vaccine to people? Ambulance officers, pathology, that's right, the people who are obviously taking the swabs. Yep, services within hospitals, food and transport. So that's all 1A, so that will happen, and the Pfizer vaccine will be available, and people in frontline, so emergency staff from Maitland, Belmont, the Mater will travel to John Hunter and get that vaccine there. So the logistics of dealing with that vaccine, which is transported at -70, are quite complex, and very grateful to the wonderful pharmacists at John Hunter who are sorting out a lot of those logistics and are currently buying big, thick gloves to prepare for working with dry ice. The phase 2 will be Indigenous, phase 1B will be next. That will be Indigenous people 55 years and over, non-Indigenous people 70, and this will be through general practice. So this will be at your practice. These will be the people you'll be vaccinating, and this will be mainly with the AstraZeneca vaccine. And again, you can be permissive. You don't have to draw a line in the sand and say, oh, I don't know if your diabetes is enough. If someone's coming, they meet the criteria, you just give them the vaccine. It's about including people, not excluding people. Then phase 2 will be Indigenous people, other Indigenous adults 18 to 54, non-Indigenous people over 50, and other critical high-risk workers. And then phase 2B and phase 3 will be the rest of the community. So this, you can see most of that work will be done in general practice. Most of that work will be done in general practice. So this huge health emergency, 1 in 100 year, it will really be general practice that will be doing the heavy lifting and vaccinating most of the community. That's why those things that Jodie talked about before about cold chain, make sure you get your fridge right. Now, if you have a cold chain breach with the normal vaccines, that you have to call us and we help you out and stuff. In this case, with these vaccines, you've got to call the Commonwealth who've paid for the vaccines, so make sure you get it right. So the vaccines will be the Pfizer vaccine at the John Hunter hub, the Oxford AstraZeneca vaccine at GP practices, and also Australia's purchased the Novavax vaccine. So we'll talk about those vaccines in some detail now. Now, the other place where obviously in the UK we saw that data from vaccinating older people. So in Australia, aged care facilities are front and centre of getting vaccinated. Now, the vaccine's been purchased and rolled out by the Commonwealth Government. Aged care facilities are funded by the Commonwealth Government. So the Commonwealth Government have engaged some companies to give that vaccine to aged care facilities. And it's Healthcare Australia in Queensland and New South Wales, and they're running that. So we don't have a lot of visibility of that. So when your aged care facility is going to be have the vaccine and they will come around, you'll have to, they said they're going to give you a week's notice. So really important at the moment that you're working on consent. So especially with a lot of residents in aged care facility can't consent themselves. So working with families, giving them information, making sure those consents are done. So when Healthcare Australia come to your facility, you're ready. So they will deliver the vaccine, deliver all the consumables, then turn up and run that program in your aged care facility. So you don't have to order the vaccine, you just have to be ready for some time when they come. Now, everyone has to do training. Everyone has to, who's going to be administering a vaccine. So that's doctors, nurses, pharmacists. Everyone who's going to be administering a vaccine has to do this training. It's also advisable for practice managers and other people who work in the practice, especially people who help with the cold chain in the fridge. So there's, if you've got an APRA, so if you're a healthcare professional with an APRA number, you use your APRA number to select the right training for you. Authorised nurses, doctors and pharmacists all do the same training. Then if you're not APRA registered, you do a shorter program, more general. So the link is there, so that's on the Commonwealth website. Really, really important that you do that training. You cannot be giving a vaccine without doing that training. So some of the training's a little bit general. We had a meeting about this training today. I'm on the group that helped with the training, and we've changed some of it, and we're going to change a lot of the quiz. Now, unfortunately, that aspect of the quiz where you do the quiz and then it doesn't let you know which questions you got wrong, that's a shortcoming with the software. That's not by design. So we can blame the technology for that, and my apologies for people that have struggled with that aspect. But please do that training. There are some good parts about it, so take the good parts and just have a glass of red through the rest. Now, this is what we thought vaccination would look like. Mass clinics. So this is in San Francisco. This is a Moderna vaccine clinic. Now, when you go to work tomorrow morning, look around your clinic. Now that is what a vaccine clinic looks like in Australia. Your clinic, your workplace. Doesn't look like this, it's your clinic. So you will be doing the equivalent of this. So you won't have big halls with lots of COVID marshals shuffling people towards your station. It will be your receptionist, your admin people, making sure that your patients get that vaccine. So there's been lots of development on the vaccines. We'll just talk about the vaccines a bit now. Now, a lot of people are worried about the vaccines have been rushed. These vaccines have been rushed out. And in fact, that's not true. So often it takes 8 or 10 years to bring a vaccine to market. That's because each phase is done sequentially. You'd be mad to build a factory to make vaccines if you haven't passed phase 1, phase 2 and phase 3 trials. But with the COVID vaccines, that's exactly what's happened. So in the early parts of the trials, they were building the factories to make the vaccine at the same time. So things are happening in parallel rather than sequential. So things haven't been shortcut, they've just been done at the same time. So you can let your patients know that there hasn't been any shortcuts. And in fact, when you look at the timelines, a lot of these vaccines were ready last May, June, and it's taken really the best part of last year to get through the phase 2 and phase 3 trials. So most of the wait has been the trials and making sure the efficacy and the safety is there, not the actual development of the vaccine. The vaccines were developed promptly because there was a lot of good technology there that could be used and just turned to a coronavirus rather than other viruses because that was the threat. But it's not rushed. So if you're talking to people and they go, "Oh, doc, sister, I'm really worried that this has been rushed and I'd never buy the first model of a car. I'm really worried about having the vaccine." You can let them know that all the normal regulatory safety procedures have been done. That won't comfort everyone, but it might help. So there's lots of other vaccines. We're going to talk about some specific vaccines available in Australia. There's lots of other vaccines in trial at the moment as well. So just recap on how viruses invade the body. So these are really nice images from nature. And I'll just do a time check. Has anyone got the time here in the room? 7:30. Great, thanks, Charles. So there's coronavirus there that we know that the coronavirus meets in the respiratory tract, the ACE2 receptor, and that grey bit there is the human cell. It gets into usually through the ACE2 receptors in the respiratory tract. Then it invades the cell, the RNA replicates within the cell, disgorges out, assembles a new virus, and then on the lower part of that grey bit there you can see new virus come out, but of course this has one virus, but of course it comes out in millions and then you have an infection. The next slide is just an expansion of the lower part of this slide and just shows the immune response. So you're all familiar with this. So the virus is met by the antigen presenting cell who presents it to the T cells and the B cells. And the T cells and B cells have helper varieties. They meet that. The B cell, the humoral immunity, makes antibodies, always depicted with that Y shape because that's the way it looks in nature. Then the antibodies can then disable the virus and then it's phagocytized or got rid of. The T cells are really, really important. So the T cells are harder to measure, but the T cell immunity is really important. So a good vaccine will give you B cell immunity and build antibodies, but also have T cell immunity. So when we're seeing how the vaccine works, we can take serology to measure the antibodies to see how that's working, but we can't measure the T cells as easily. So there's often a whole arm of the immune system that we can't tell. Now, the vaccinology with these vaccines, now a lot of them are conventional approaches, but there's a whole lot of new novel approaches. And I'm really hoping this huge energy and investment in these novel approaches, some of the intractable diseases that we've had around the world for decades, if not centuries, will be able to turn some of these technologies to thinking about RSV and viruses like that. So let's hope that this is a vanguard of a whole lot of new technology to get rid of a lot of intractable illnesses. So the gold standard is the neutralising antibodies. So you'll read in the even in the popular press, they talk about neutralising antibodies. So we really want a vaccine that makes neutralising antibodies. So some vaccines will make antibodies that will disable the virus, but it can still replicate and cause a mild illness. Won't put you in hospital, but we really want a neutralising antibody. And when we think of, we can see along the age spectrum, younger people respond to the immune response to the natural infection of COVID-19 a lot better than older people, and that's probably because one of the reasons is they're much better at making neutralising antibodies. So this is a nice schema from Katie Flanagan's paper. Katie's an infectious diseases physician in Launceston, Tasmania. She's got a terrific paper, came out at the end of last year, with some great graphics about the various vaccines. And you can see them branched off into different types of technologies. And the types of technology, most of they're really well represented in a lot of the research that's being done. So first we'll just look at the protein. We'll look at the 3 vaccines that the Australian government have purchased. So the Novavax vaccine is a protein vaccine. You can see there the little red squiggly bit, the DNA, that's put into another virus. That virus is infected. That big green thing is actually a moth cell. They put that virus they've put in the baculovirus, that goes into the moth cell. Then the moth cell just goes through the normal replication in the moth cell, and then the spike protein is expressed on the external. Then those spike proteins are gathered and put together into clumps. So those spike protein are gathered together and put together into nanoparticles, and you can see that with that flower arrangement there. So those bigger vaccine nanoparticles then meet the antigen-presenting cell, then meet the helper T cell, and that's how immunity is formed. So that's the Novavax technology. So that is a similar technology to Gardasil. So that's how they make Gardasil, is by infecting a cell, gathering the antigen, putting that together, and then using that to make the vaccine. So this is a technology that we do have in other vaccines that we're familiar with. So Novavax is a protein vaccine. One of the interesting things about the work done on the Novavax, there was a paper about infecting macaque monkeys with COVID disease after they'd been vaccinated. So this is interesting because this diagram from that paper, on the left-hand side, you can see the placebo. Then there's 3 groups of the Novavax protein vaccine in 3 different doses, the 2.5 dose, the 5 dose, and the 25 dose. And that's both the same in diagram E and diagram F. So what they did was they vaccinated the macaques, infected them with COVID-19, and then they did, on the left-hand side, a bronchial lavage, and on the right-hand side, nasal swabs. And you can see there the placebo, they got lots and lots of virus. But even with the low dose, so the 2.5, 5 and 25 Novavax macaques had no infection. So this goes to that whole idea of asymptomatic transmission. So even when they look for virus after vaccination, they didn't find any. So this is really promising for that vaccine. Now, the next technology we'll talk about is the mRNA vaccine. So the mRNA vaccine is literally, so the RNA is the code that makes virus, and usually we encapsulate things in something else and then give that in the vaccine. But in fact, the mRNA is just using the mRNA, so it's the messenger RNA. So one of the companies in America is the Moderna. If you look at the word Moderna, it ends in RNA, so that's where they get that name from, the M, messenger, Moderna, RNA. Now you can see that RNA is just floating about, then that infects the human cell, then the human cell uses that RNA in its normal processes to make spike protein, because that messenger, the message in that RNA is to make spike proteins. Those viral proteins are expressed inside the human cell, then expressed on the outside, then they meet the antigen-presenting cell and go through the immune response that we described before. So that's a direct effect of the messenger RNA. You can see on the top of that diagram that messenger RNA is just floating around by itself, so that's why it's incredibly fragile. So this is the Pfizer vaccine, uses this technology, the vaccine we'll be using in Australia, and this is why it's transported at -70. There's some really detailed instructions on how to use this vaccine, and you've got to be very gentle with it, because if you disturb the messenger RNA, it's not going to work properly. This is a picture of my garage where I've got the deep freezers at home, storing the vaccine ready for being transported to John Hunter on Monday. This Pfizer's actually developed a whole series of ice chests to transport this. You can see the middle there is the pizza boxes. This is packed with dry ice, and they're kept and sent around the world and monitored from Germany. And this is what those little pizza boxes look like. There's 195 vials, multi-use vials inside each pizza box. Now, if you're working at John Hunter, there's a wonderful set of, on the New South Wales Health website, for both the Pfizer vaccine and for the AstraZeneca. I really recommend you read this. It's got detailed steps of how to mix up this vaccine. Now, we're not used to working with multi-dose vials, so you do need to switch on and use them properly. So I really recommend these two. You can see they're just been released not long ago. So they're on the New South Wales Health website. Now, the vaccine that you'll be using in general practice is a non-replicating viral vaccine, non-replicating viral vector vaccine. So this is the same different set of instructions, but from the same place for the AstraZeneca, and I recommend that to you. And that's what it's going to look like in your fridge. So that vial contains, depending when it was released, 4 mils or 5 mils. This is the using the multi-dose vial. So one thing you don't want to do, quite obviously, is suck up a dose, leave a needle in the bung. You think, I don't want to puncture the bung again, I'll just leave the needle, stick it back in the fridge, because then you obviously got an introduction of bacteria into that vial. So you don't want to do that. Now, there'll be different stocks. So the middle line there is imported stock type 1. That's obviously what you're going to get first. Each dose is 0.5 ml. So if you're in general practice using AstraZeneca, it will always be 0.5 ml. The vial's 5 ml, so that's 10 doses. Now, when Broadmeadow start making the vaccine, so that's Broadmeadow, Melbourne, not Broadmeadow, Newcastle, it'll be the same. It'll be 5 mils and you'll get 10 doses out of it, and we should have that vaccine soon. So it's really important that you don't, if you only can get less than 0.5 ml from the vial, that you don't then mix it with the next vial. Each vial must be independent. So if you can't get 0.5 ml, you dispose of that and don't use it. And the stability of the vaccine inside a syringe hasn't been studied. So once it's drawn up into a syringe, you need to use it straight away. If that's sitting around, then you need to throw it out. So this vaccine, the reason it's been used in general practice is because you store it between 2 and 8. Now, on the left-hand side there, you can see that you can use it. It can sit for 6 hours at room temperature, and that's an accumulated time. And then you need to dispose of it. And 48 hours total since it was opened if it's been returned to the fridge. So how does this vaccine work? So you can see the diagram there of the coronavirus with the spikes on the outside, and you can see the spike protein gene there is the squiggly red bit, and whereas the Pfizer vaccine uses the RNA, that's a double strand of DNA, and that double strand of DNA is put inside an adenovirus, and that adenovirus is quite hardy. So you can see there that that double strand of DNA inside the adenovirus is quite protected, so it's very hardy for environmental conditions and will last quite well, which is why it's got quite good thermostability. You can store it in a normal vaccine fridge. Now the chimpanzee, so that's the ChAdOx, the CH is for chimpanzee adenovirus, because if we used a human adenovirus, we've all met those before, we've all got antibodies to human adenoviruses, and that could be destroyed before it does its job. Then it deposits the DNA inside our nucleus, and then messenger RNA is made, and then that is transcribed and translated, makes the spike protein. Spike protein's expressed on the outside of the cell, and then the immune system recognises that, and you make antibodies. So in the UK, they found, and Vaccinology 101, the longer interval between vaccines, often they'll work better because your antibodies will fall to baseline, then you stimulate them again. They started off looking at 3 weeks for this vaccine, but have gone to 12 weeks. And in the UK, they're using 12 weeks for both the Pfizer and the AstraZeneca vaccine. And with 12 weeks, it works quite well. So what's the efficacy? The efficacy is very good. So for the AstraZeneca vaccine, there's lots of concerns in the community about the efficacy of this vaccine. People say, oh, I only want the Pfizer vaccine because it works better. But in fact, the real world data is showing that it works really, really well. So the hospital admissions in the trials were low, and the efficacy is about 70% after 14 days after the second dose with the AstraZeneca vaccine. So that's a really good vaccine. The Pfizer vaccine, quite famously, is 95% efficacy, and I stole this slide from Michael Boyle the other day, so thank you very much, Michael. So in the trials, 9 infections in the vaccination group, 169 in the placebo group, and that's where the 95 efficacy comes from. But in the Oxford vaccine, they actually used, they actually did a lot more investigation. So they actually had more cases in the vaccine arm, but that's probably because they investigated a bit more with PCR testing. They didn't do that with the Pfizer to give better results. And again, we're interested now what's happening in the real world. So there's a paper from Scotland, it's in preprint, Burnell et al., and they say they look at both the Pfizer vaccine and the AstraZeneca vaccine in the UK, and they found that even in older adults, it has a great efficacy, both of those vaccines. And the AstraZeneca vaccine, because it's 3 months between doses, they're actually looking at a lot of people after they've only had 1 dose, and they found really good efficacy in older people. So this is a verbatim from their conclusion, that in older adults, with either greater protection against severe disease, both vaccines showed similar effects. A second dose of the Pfizer vaccine gives further protection, but second doses of the ChAdOx vaccine, the Oxford vaccine, haven't been studied. And it says there's good effects on the UK variant of concern. So the Israelis have vaccinated more of their community than anyone else. This is a paper from the Israeli data. If you just Google up the search for the New England Journal of Medicine. This is look at their corona section. This is the top paper in their corona section because it's big news. This is working really, really well. So they've used the messenger RNA, the Pfizer vaccine. You can see those graphs on the right-hand side. They're a bit small, but the general pattern is that the red is unvaccinated, the blue is vaccinated, and we're seeing much less disease. So the Israelis think the vaccine's working really well, and they had a huge program. So the variants, we'll just talk quickly about the variants. There's concern about the variants. What do the variants look like? I saw this from Professor Karim in South Africa. It's not my analogy, but to the end or till questions? Oh, to the end, okay. You can see there's the, if you think about the spike protein, there's an analogy is the torso. you can see there the left shoulder, the right shoulder, the neck, the chest, and the right flank and the left flank, and that's a great way to be able to view the spike protein. And you can see the variants of concern down on the bottom right. So the one on the far right is orientated the same as the torso, so you can find your way around the spike protein. And the receptor binding domains of concern are in green there, and that's where they meet the ACE receptor. And this particular one, normally the spike protein and the ACE receptor are both got the same charge, but this variant of concern has a different charge and is able to attract itself. Now, if that all looks very confusing, here's one way to understand it. This is B1. That's the Australian variant. This is the UK variant, B117. That might help you to be able to understand. So that might be easier than the torso analogy. Okay, I'll just confirm. So how are we going for time, Charles?
So we still have 40 minutes.
Okay, great. So we've got time for questions at the end. Fantastic. So the adverse events are what you'd expect from most vaccines. This is the list of the adverse event from the AstraZeneca vaccine that you'll be giving. So injection site tenderness, 60%. So over half the people are going to get a sore arm. Pain, 50%. Hotness and itching at 10%. Headaches in over 50%. Fatigue in over 50%. Myalgia, muscle pain in 40%. Malaise, 40%. This is the phase 3 data. Fever, 30%. Arthralgia and joint pain, 20%. And nausea, 20%. You need to be informing people that they're not going to feel too well the next day. You need to be giving them strategies of how to cope with that, because without that, they're going to be back knocking on your door saying, "Doc, you gave me that vaccine yesterday and I feel terrible." If you tell them they feel terrible, they're going to stay at home and feel terrible with normal medication and not come back and bother you. So really important that we inform people. Yes, this vaccine will knock you around, but then we can open up the world. It's worth it. So informing people is really, really important. The other thing is that your younger people, healthier people, are going to feel this a lot more than older people. Older people, you're a young youthful audience, you might not know, but as you get older, your body doesn't work quite as well, including your immune response. So if you've got a really good immune response and you have a vaccine, you're going to get a much bigger response if you're younger and healthier. So younger people will feel these normal adverse events, common adverse events, more so than older people. But the experience is that they're self-limiting for 1 or 2 days. Really important that you help them manage the pain of the injection site and make sure they've got some paracetamol or something similar at home and that they're looking after themselves. Cold compress, all that advice that you give people is really, really important. So managing adverse events is really, really important. So this vaccine, the procedures are a little bit different. So the Australian government have online reporting for when you receive the vaccine, online reporting for stock management of the vaccine. So you've got to report in how many doses you've used regularly. And if you do have any wastage, as Jody pointed out, over 5 vials at a time, then you must report that directly to the Commonwealth website. And when you get the vaccine, you'll be given those logins on how that works. And you can see that's an electronic form. You click the link at the foot of the thing and report online. So really, really important stock control. You can't just, have someone unplug the fridge, the whole thing goes off, just ring us and we send you some more vaccine like what normally happens. So really important that if cold chain's not your thing, make sure it's the thing of someone at the practice, that they're running that really, really carefully. Through the House of Reps and the Senate, the mandatory reporting to the AIR passed a few months ago. So really important now that you have updated practice software. Sometime the practice manager likes to save a quid or two by not updating that practice software. Really, really important because now that's law. You must, if you give a vaccine, you must report it to the AIR. So you must have the latest version of the practice software and use your Proda account. For general practice, it's fairly straightforward. For people working in hospitals and community health, it's a bit more complex, and we'll give you some more information on that soon. So we take vaccine safety really, really carefully. I've been running the Vax Tracker program for a while, which is an active surveillance program, and that data's been up on the AusVac Safety website for a few years with graphics like this showing that the vaccines are safe. So we've been using this for the Gardasil vaccine and for other vaccines. So the AusVac Safety website's really useful, and now AusVac Safety's got a big program looking at the safety of the COVID vaccines. And very excited, this is the TGA website, and if you go to the TGA website, you can see there the COVID vaccine weekly safety report from the 3rd of March. So that's mainly Vax Tracker data there. You can see there that 11,000 surveys were filled in. We've now got over 20,000 surveys in Vax Tracker. It's grown since last week. So these are people mainly getting the Pfizer vaccine in hospitals all around Australia. 64% reported no adverse event, 36% reported some adverse event, and 0.7% sought medical attention after the vaccine. So that's really good. So we do signal detection on this data every week to make sure that the vaccine's behaving in the real world as the phase 3 trials, as Pfizer said it would, and we're starting to see some first lot of data for AstraZeneca come in. Now there's 2 vaccine safety software programs that report to AusVac Safety. There's the Vax Tracker program we developed locally, and the SmartVax program from Dr. Alan Lieb, a GP in WA. And a lot of you will be working at practices that report data automatically to Alan's program, and Alan will be in touch with you to update that so that you can also report the COVID vaccines. So if you're not working with SmartVax in your practice, there's an option we'll have developed hopefully in a week or a bit where we've developed a QR code. So if you're watching this on a laptop or something, you can put your phone up and scan that QR code on the screen, and that will take you to the Vax Tracker website. So the idea is that you'd have the QR code in your recovery area, in your waiting room. Someone would have the vaccine, then they would scan the QR code, then put their details in. That would come to us in Vax Tracker, and then we can follow them up and report that data to the TGA, and their data would be included in the national vaccine safety data. So if your general practice is interested in doing that, if you're not a SmartVax practice, then please be in touch with me, please contact me, and we can help you do that. We're just at the tail end of getting all that fixed up, and that should be ready during the week of the 22nd of March, when you guys will be starting to give the AstraZeneca vaccine in some practices. So please be in touch. Now you can, we all saw in the news that Greg Hunt had the vaccine a few days ago, then got crook. Now he seems to, from the news reports, I'm not in touch with Greg personally, he seems to have a bacterial sepsis. He's had that before, so this seems to be coincidental. That's nothing to do with the vaccine. And you'll see a lot of this. Your patients get sick. They get sick without having a vaccine, and some of them are going to have a vaccine and get sick. But it's really important that we report AFI. So if Greg Hunt was your patient and he had bacterial sepsis a few days after having the vaccine, you don't decide whether you think it's causative or not, you just report it on as an adverse event, any serious event. So the key here is it's adverse events following vaccine. You're not deciding whether it's caused by the vaccine, because we want to know everything that happens, because if things happen, maybe something happens in Newcastle, something happened to Greg in Canberra, something happens to someone in Perth, and then we can put that data together at the TGA and see that maybe there's a pattern happening. But if we just think it's something nothing to do with the vaccine, those patterns will never be found. So please report adverse events following immunisation. So the trials from the messenger RNA vaccines, there were some cases of Bell's palsy, 7 in the trial group compared to 1 in the placebo group. And everyone at home sort of dropped their jaw on one side going, what? So this is it was significant in the trial. So we're not expecting to see any Bell's palsy, but that will be something that you would be looking out for specifically. So if someone does have Bell's palsy in the month or two following the vaccine, then you would report that as an adverse event. So there's a new paper looking at vaccine reactions. So this is a case series of 12, and the median onset of these big red arms was day 8. So it looks like a delayed T-cell hypersensitivity response. It's a good little paper. It's only short, but this photo is pretty impressive, and you can see their pairs there. So having a local reaction is not a contraindication to having a second vaccine. So all 12 went on to have dose 2. 6 had no reaction to dose 2. 3 had smaller reactions than their first reaction, and 3 had the same reaction as the first time. So all subsets, so no reaction, smaller reaction and the same reaction were represented. So that's 6, 3, 3 in this 12 case series. So this was actually with the Moderna vaccine from the United States, a vaccine we're not using, but the Pfizer vaccine is similar. You may see some. So again, this is not the following day. The median onset of this reaction was day 8. So look out for these reactions. Now, one person went on to have IV antibiotics and hospitalised. So that's unnecessary with a local reaction. If the person's not systemically unwell with a fever, so obviously investigate for sepsis and treat as you see fit, of course. But often these vaccine reactions don't require antibiotics. They're not infection. It's a local hypersensitivity reaction. And be guided by how unwell the person is and treat appropriately. So this is something we may see. As I say, this is the Moderna vaccine, not a vaccine we're using, but the Pfizer vaccine is similar technology. And again, that's on the New England Journal COVID homepage, and worth a quick look. It's only a few short pages. Now, the disease itself can cause some funny things. There's a paper from Spain about chilblain type reactions from COVID disease. Will we see funny things like this from the vaccine? We don't know. And if you guys don't report, we won't know. So it's really important that the public have confidence in the vaccine, and that we're not hiding anything, and that we report, and that the TGA has good, transparent data. So please report adverse events. So reporting adverse events, unlike everything else to do with COVID vaccines, is boringly normal. You fill out the normal adverse event form and send it to us at the local PHU. So the state government are handling adverse events. So you send that to us at our website in the usual way. And we will investigate it. Now, it's really important that so there's 2 things to an adverse event. One is the clinical presentation. So if someone comes back to you after having the vaccine and they're fatigued with a headache, you treat them clinically and look after them, whether that's symptomatic treatment or if you're worried because of your clinical examination and you think there may be some other cause of the headache, then obviously you need to refer them and do investigation. So the clinical management of the case is with you in general practice. The public health follow-up of the case is with us in public health. So please fill in the adverse event form so that we can report that onto the TGA, and we will follow your clinical management. So if someone's got ongoing headaches and you refer them to a neurologist, we'll be following that along. If especially important, if someone's just had the first dose, that we help you decide whether they're going to go on and have that second dose. And Michael Boyle, immunologist from John Hunter Hospital, will be helping us. Now, obviously, most vaccines pre-COVID are given to children. These vaccines are going to be given to adults, only years 18 up at the moment, working with adult immunologists. So please use your clinical acumen, report adverse events so we've got a transparent system, take good clinical care of the person who's got an adverse event. Don't assume it's the vaccine. You don't want to miss something else because you're thinking the sign or symptom someone's presented with is the vaccine. What we consider common adverse events such as myalgia, fatigue, what else do we have up there? All those signs and symptoms, headache, manage those properly so that people aren't concerned. Now, equity is a big thing. Here we are in Australia with no disease, and we're getting vaccines before a lot of other countries. So there are a lot of our near neighbours. New Guinea's been in the news lately with some nasty COVID. Indonesia's got one of the largest COVID problems in the world. And here we are sucking up a lot of vaccines. So this window is really, really important. We're very privileged to have this window, so make sure we get that vaccine out there and vaccinate as many people. The COVAX facility is an international facility where rich countries are putting aside a part of their vaccine investment, and then that's going to be given to poorer countries. But look out for what's happening internationally, and Australia's contributing to that COVAX facility. I guess the main message is to be technically proficient, to communicate really well with your patients, vaccinate as many people as you can. You've got a really important role in general practice to be getting this vaccine out to the whole community. The other people that the vaccine will come to, I don't know when, I'm assuming phase 3 will be community pharmacists. Make sure you report adverse events, and we've got a really safe, transparent, trustworthy system of vaccination that people will have confidence in and come to your practice or pharmacy or clinic and have the vaccine. So I guess they're the main messages. And then I think we've got time for some questions. Charles, how are we going? Yep. So we've got some, Jodie and Sharon have come to be able to answer the questions. Because that's how it works at our place. You got the questions in front of you?
We've got
Yep.
lots of questions.
Lots of questions.
There have been several questions about who falls into Category 1B. And I was just going to say, on the Commonwealth COVID-19 site, there's an excellent presentation on Category 1B. So it'd be really good to download that. It goes through all of the different people who qualify under 1B. And it's quite succinct, actually. Yeah.
So did you just Google Immunisers Australia COVID 1B?
I will tell you what I Googled.
Because, as we know, there's lots of information out there.
COVID 1B eligibility. There you go. And I just Googled to the Commonwealth site, and it was very informative.
Okay, that's great, but we don't have to be really strict with the lines in the sand. If you think someone's 1B, then they're 1B.
That's right.
Yep.
And just on that, Patrick, one of the questions was, it's come to the end of the day, you've got some vaccines left in your vial and no 1B patients left in your waiting room. Who can you give that to? The Commonwealth Government was, I think they were clearly stating it goes to whoever else is there. So you don't have any 1Bs, but you've got vaccine that needs to be used before it's expired. They want it in arms, not in bins.
Yep, just ensure that person's available for the second dose.
Yep.
You don't want to be giving a dose now and fire someone the next day and they're not around in 3 months' time to have the second dose. So it's anyone who's around in 3 months to have that second dose, then yeah, give that first dose.
Dare I say you have your staff?
Yeah, that's right.
Yep, your staff that you're holding on to because they're brilliant.
Yes,
yep,
exactly.
Right. So, Patrick, a history of GBS, is that not Group B strep, Guillain-Barré syndrome, is that a contraindicator to COVID vaccine?
It's a great question. The short answer is no. With influenza, virus, disease can cause GBS. GBS has an infective cause, most commonly after diarrhea with Campylobacter. And sometimes in reports there have been about 1 in a million after influenza vaccine. So if you get GBS after influenza vaccine, then the recommendation is not to have any more influenza vaccine. If your GBS is caused after Campylobacter or some other infection, then it's not caused by influenza vaccine, then it's okay to have the vaccine. And it's the same with COVID. So if your GBS was caused by COVID vaccine, the recommended is not to have it. And obviously, no one who's had previous GBS, it was caused by COVID vaccine. So the recommendation is it's okay to have it.
And just in case we've got any hospital staff listening in, Patrick, adverse event reporting for hospital staff's a little bit different.
It is.
I'd like to talk to that.
You would.
So if you're in your local hospital and a patient comes in, as Patrick was saying, with symptoms, you're not allocating causality. You've got a patient presenting in front of you with, just guessing, 4 days of severe headache. They happen to have had a COVID vaccine 4 days ago. You don't know what's caused what. You're treating the patient and their symptoms, but you may also wish to refer that as an adverse event following immunisation. And emergency departments have your own special form now. So by all means, you can find that on the New South Wales Health website, or ring your local public health unit and we can email you the form for you to complete. It's different to the national form that Patrick was showing us. It's a modified version for New South Wales public hospitals, or New South Wales Emergency Department, sorry. Yeah.
Thanks, Jodie.
So Patrick, we've had some questions about people who are immunosuppressed as well. And do they need to take extra precautions?
Yeah, so immunosuppression, we do worry about vaccination and immunosuppression, but in general, it's only live vaccines where we need to worry. So the obvious vaccine that we're giving regularly is the Zostavax. So that's quite a strong, for want of a better term, live vaccines, 14 times stronger than the normal varicella vaccine. So if you had someone who is severely immunosuppressed, there's a risk, a small risk, but it's happened where the viral vector can replicate out of control, overwhelm the immune system, and there's been, I think, 2 deaths in Australia where the vaccine's been given inappropriately to someone who's immunosuppressed. So live vaccines and immunosuppression don't go together. We're very, very cautious, and there's some good guidelines in the Immunisation Handbook. None of the vaccines that we talked about, the Pfizer vaccine, the AstraZeneca vaccine, or the Novavax vaccine are live, so those risks aren't there. So the only risk is that your patient won't respond to the vaccine well enough and have lower immunity and not be as well protected, but there's not a risk of adverse events. So people who are immunosuppressed, they're the people on our 1B list, and they're the people that you want to give the vaccine to first before the virus comes into the country later in the year. So immunosuppression's not a reason not to give the vaccine, it's a reason to seek those people out and offer the vaccine. Obviously, follow them up, make sure they're okay, but the risk is of disease, not of adverse event.
And we've had lots of questions, Patrick, about the timing of vaccines, timing of COVID and Zoster or flu or Pneumovax or Prevnar. Is there a standard recommended gap between Zoster and any other vaccine?
There is for influenza vaccine of 2 weeks, which I think we extrapolate to all vaccines, is that right?
Yeah, certainly what we've been saying.
Do you want to fill me in? Yes?
Yes.
We concur.
Yeah, good answer. Yeah. So the recommendation is 2 weeks.
2 weeks between any vaccine and COVID vaccine.
Well, we need to check on Zoster vaccine, actually.
That might be different, Yep.
Okay.
Okay. So Zoster's pending, otherwise it's 2 weeks. So we don't give COVID vaccine, other vaccines at the same time, but leave a 2 week interval.
The one thing to say, possibly if you happen to have some patients that have had the Pfizer vaccine because they're healthcare workers that fit into that category, and your flu vaccine comes out, because you've only got that short space of time in between your 2 Pfizer vaccines, not to interrupt it with a flu vaccine.
Yeah, absolutely.
Was it 1-2 flu?
1-2 flu.
For Pfizer? Yep.
Yep. Where it's different with the AstraZeneca.
Yes.
So in general practice,
That's right.
you would give the AstraZeneca when it's available. As long as it's not a 2 week interval, give the influenza when it's available, and then follow them up for that after 12 weeks to give the second dose of the AstraZeneca vaccine.
And we're getting heckled by our colleague, Angela, suggesting we only ask you questions that you know the answers to. So, apologies for that one, sorry.
Yes, don't go off the list that I gave you earlier.
No.
Yeah.
So we did get a question about, is it compulsory to add vaccines to air, to COVID vaccine? I think you covered it, but just...
Yes.
Yep. Essential. Yep. And for any Hunter New England health employees. So any Hunter New England staff that access the Australian Immunisation Register, please make sure you send your PROTA number through to us so we can allocate you to an organisation so that you can continue to have access to AIR when they turn off the authentication files. So that's really important. Get your PROTA number, send it through to the public health unit so that we can, sorry Todd, so that we can allocate you to a organisation, otherwise you'll lose your access to AIR.
And there's an expectation when people are coming to general practice for their second dose that you'll actually check when and which vaccine they had on the AIR. So there'll be a manual step there of looking people up, checking when they had their dose. If they're your patient on your software, then that will be sufficient. But so accessing the AIR in general practice, it's always been a good idea, but now it'll be a really important part of your practice.
There's been a little bit of concern too about whether the flu vaccine rollout's going to be staggered because they're going to get COVID vaccine at the same time. The answer is we haven't heard about a staggered rollout of flu vaccine. In fact, right. It varies every year. But keeping in mind that the COVID vaccines come in multi-dose vials, so you're going to get 200 doses. You're not getting 200 vaccine vials. So.
Yeah, in terms of fridge space?
Yes, as far as fridge space goes, it takes up less space.
Yep. But the advice is not to anticipate when the influenza vaccines turn up. So don't book staff and clinics for influenza vaccine ahead until you get that vaccine in your fridge and you know what you're dealing with.
Yep.
So it's very difficult to plan. Apologies to the practice managers, but that's the advice.
My turn? We had a question about do we recommend a UPS or a backup battery for the vaccine fridge in case of power outages?
So is that a question for Angela?
Yeah. I think Angela would concur that if you have frequent power outages in your area, then investing in battery backup would be perfect. Be a great idea. We've had lots of questions about how long is the vaccine stable in the syringe once it's drawn up. So as Patrick said, and your training package says, there's been no studies on how long the vaccine is stable once it's been drawn up into a syringe. The training package says to use immediately. The New South Wales package is not that specific, so hopefully the federal government will provide better guidelines once they become available. At the moment, the answer is immediate. And what's immediately, I don't know. But let's watch this space. The Primary Health Network is putting together a toolkit for COVID clinics. So we'll make sure that's a question that they'll have in there as well. I don't know if they'll have an answer, but we'll make sure we have a question there.
Yeah, so the idea would be not to prepare lots of syringes in advance. My understanding from the PHN is that the Commonwealth are not providing needles and syringes to general practice. You're providing your own. You would have seen lots of news about the low dead space needles and syringes. Seems to be that they're of premium and that they'll only be going to the Pfizer hubs, and there's not very many of them. So you'll be using conventional needle and syringes. Is that right, Sharon?
I think so. And the AstraZeneca New South Wales guidelines talk about using the same needle to draw up and administer. So you don't leave a needle in the vial and draw up. You use the same needle to draw up and leave that on the syringe to administer, so you don't lose any of the dose.
Yep, we've been a bit spoilt in medicine in the last few decades. Before that, there was a lot of use of multi-dose vials for things like local anaesthetic and things like that. And there were cross-infections, a sad case in Randwick of HIV transmission to 5 or 6 people with common local anaesthetics. So everything's single use, and that stopped a lot of infections. This is multi-dose because of the volume. In Australia, we think multi-dose is a bit unusual. In a lot of countries, it's business as usual. A lot of vaccines come in multi-dose because you can move a lot more vaccine more quickly for more people. But it does require a lot more careful. We don't want infections from poor technique with the multi-dose vial. So the most obvious one's leaving the needle in the bung. So piercing the bung multiple times is not an issue. That's okay.
So Andrea has asked, we sent out a red cap survey. Hunter New England sent out a red cap survey, or Patrick did, asking for Hunter New England nurses to fill in a survey of who was available and who was up to date. Andrea is asking why we didn't include non-Hunter New England nurses.
Oh, yeah, good idea. If you're a non-Hunter New England nurse, it's up to you to keep up to date. That's the same for Hunter New England nurses. We were specifically looking for staff for the Pfizer hubs. So we were looking for people that worked in Hunter New England that we could call on. So if you are a Hunter New England nurse and you do want to help with the rollout of vaccines in community health, MPSs and other government facilities, you must do the training and send that in. I've sent some emails about that. If you haven't done the training and sent that in, then you won't be considered for those roles.
Brilliant. Yep. Have you got any more questions?
No.
Okay.
No more questions?
So
for Hunter New England nurses, we hopefully what we filmed tonight will be on the My Health Learning website, and you'll be able to view that or tell your mates to view that, and they'll be able to look at that and then have that on their training record. Are there any certificates available, Charles, for other people? Not for live streams. So no. So just keep a record and add that to your training record.
So Patrick, we've got a question here. What are the contraindications to a second dose of the vaccine?
Oh, that's a very good question.
Yeah.
So that would be anaphylaxis or severe allergic reaction to the first dose.
Yep. Okay. So anaphylaxis is the only contraindicator. Anaphylaxis to COVID vaccine is the only contraindicator. But you may have had patients that developed a rash and you're concerned about that. We'll get that adverse event following immunisation form from you and provide recommendations. And we've just got a person here saying the Commonwealth information they've been provided says that the federal government is providing 3 ml syringes, 25 gauge needles and sharp spins.
Oh, fantastic.
That's in their onboarding information.
Oh, great.
Yeah.
Okay.
Yep.
Oh, great. I stand happily corrected.
Yeah. So we don't know if they're going to come with the vaccine or you should have a little stash ready. Yeah. Yep.
Actually, that's a really good point. The Commonwealth have provided a really nice onboarding package for general practice where a lot of detail is there and it's really worth reading thoroughly. The other thing to look at for general practice is the health pathways. I know you're in there all the time. That's really, really fantastic for all sorts of healthcare that you're providing. But COVID vaccine is no different. It's a really good first point of call for information on COVID vaccination. But the onboarding package is very detailed and really worth having a look at in some detail.
And a special shout out to Simon Holiday. He's got his Jimmy Jams on, watching.
Ah, Simon, fantastic.
Yeah.
Simon, who was in the Australian newspaper a few weekends ago.
Oh, and Vicky's asked, are there likely to be any adverse events if you're given the COVID vaccine and you currently have COVID and unaware that you have it?
Oh, that's a great question. Yeah, so if you... no, I think the answer's no.
Yeah.
Yeah, so that's right. So we have our normal social distancing precautions. We don't want lots of people coming to your practice and someone just happens to have COVID. But you don't have to do any COVID testing. We still give it to people. And the immune response to the vaccine is so good that even in places where lots of people have had COVID disease, like in Europe or in India, the recommendation is that you still have the vaccine. Having the disease is not a guarantee of immunity, and the vaccine's still recommended. Yep. So there's having COVID disease. If someone's obviously unwell with COVID disease, you wait till they recover like we do normally.
Because you wouldn't want them in your practice
You wouldn't want them in your practice, that's
Yep.
right. But yeah, so there's no contraindication to someone who's got COVID disease having the vaccine, any of the vaccines.
And Leonie's advised that in their onboarding information, it says that the vaccines will come with the consumables, that they'll all be delivered at the same time.
Oh, okay, great.
So this feeds back to what Patrick was saying at the beginning. We at Public Health don't get the same information that you're getting in GP land from the federal government. So it's really great that you're sharing this with us. Thank you. Sharon, were there any new questions that we missed? We've got a question about Prevnar. Shall we branch off COVID for a brief minute?
Yep.
Okay, we've got 6 minutes. So, a 58-year-old gentleman, Aboriginal gentleman who smokes and had a Pneumovax 23 2 years ago, because Pneumovax 23 is recommended for people who smoke tobacco.
Correct.
What should he have now?
So he'd have a Prevnar 13 now,
Yep.
and then you'd wait 5 years after his previous 23
Yep.
and give him his second and then stop.
Second and final. Yep, that's...
Yep. Is that what you do?
I think so.
Yep.
Yep. And then I double check the recommendations in 5 years
Yes, good point.
and see what they are then.
Yep, yep.
Yep.
It's just going back to COVID. There's one question here about scheduling appointments. Could we schedule our patients a bit sooner than 12 weeks to ensure people didn't miss their appointment and go over the 12 weeks?
Oh, okay, that's a great question. I don't know the answer. Just from Vaccinology 101, generally a shorter interval between vaccines is not recommended because the body needs time to build an immune response and fall to baseline, whereas usually an increased interval would be okay. So the trials were initially kicked off with the AstraZeneca vaccine, the Oxford vaccine at 3 or 4 weeks, and then they went to 12 weeks and got a better immune response. So someone who comes in after 12 weeks is probably better than someone who comes in before 12 weeks. So in general, for vaccination, slightly later is better than slightly earlier because of the way vaccines work and the immune response works. You don't want to, of course, have it's such a long time that people are in danger of getting sick because they haven't had their second dose if they're exposed to the pathogen. So yeah, you do want people to come in and get vaccinated, but in general, you don't shorten that period. So no, I would wait a full 12 weeks, and if they come in a week or two later, then that's okay.
And we've got a question from Anne regarding, from Candy regarding COVID vaccines and pregnancy.
Yes, so COVID vaccines are not deliberately given to pregnant people. So if you're pregnant, at the moment we're not offering COVID vaccines. Theoretically, there should be no risk. These are not live vaccines, so there's no theoretical risk. These vaccines are brand new. We really don't know a lot about them. There were no pregnant people in the trial, so at the moment we're not giving them to people who are pregnant. So especially in Pfizer hubs with hospital, a lot of young hospital staff in the age group where they could be pregnant. So if you could be pregnant, the advice is not to have the COVID vaccine.
So I think in answer to lots of the questions that are on here, we don't have access to the same information that you've had on your onboarding kit. There's an email address and a phone number, we understand, that comes with your onboarding kit. A lot of those questions will need to be redirected back to the federal government.
Yeah, that's a good point, Jody. So I asked someone quite senior about consumables in general practice. A very short period of time, they said, no, they've got to do their own. Then the onboarding thing came out and said they're going to be supplied. So, so that is really good news. But yeah, so read your onboarding, look at your health pathways, look at the New South Wales Health website, look at those that guidance on the AstraZeneca, giving the AstraZeneca and how to look after it. And keep in touch with us. We'll help you as much as we can. Look for the Commonwealth materials because this is their vaccine and they're rolling it out. And good luck, and let's get this vaccine out to everyone. Use this window. So at the end of the year when that virus comes, we see a lot less disease than we would if we don't get a lot of people vaccinated. Good luck, keep in touch. Ta. Thanks, Charles.
Thanks very much, Patrick. Thank you everyone for attending tonight and also for entering all of your questions. It's been fantastic. I just want to take the opportunity to warmly thank Patrick, Jody and Sharon for generously giving their time tonight, for providing that wealth of information that, as we know, is very timely and very important at the moment. So thank you again. Just a reminder that we are holding a session tomorrow. The PHN is running a mastermind webinar at 1 p.m. tomorrow. The focus of this will be general practice preparedness for rolling out the COVID vaccine in your practice. So you can just head to our website, click on the education tab, and you'll see our upcoming events. So just click that and you'll be able to register. So just a reminder that tonight's event, we would love your evaluation. So you just click on the polls tab. If you could quickly fill that out before you log off, we'd really appreciate it. And that's all from us tonight, and we hope you have a great evening. Good night.
Talk about forever, talk about the weather, to know any better. I just want to laugh until I can't breathe. Midnight moonlight dancing, never get enough sleep. Oh, the whole night through. And we could count the distant tumbling stars from the roof of our cars, letting go of our hearts. Close your eyes, pretend that it's your first kiss. Darling, can you feel it? Oh, so ignorant bliss. Oh, the whole night through. 'Cause we don't wanna grow up.